You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 8th, 2019. This week, N of 1 trials, heart failure, insulin, chest pain evaluation, and the peripheral artery disease stent controversy. First topic is about blood pressure and N of 1 trials. So every single day, todos los días, doctors have to choose treatments that have been studied in trials for their individual patients. And trials are great because randomization balances confounding factors. But trials produce average effects for their selected patients. What they don't tell you is how that therapy will perform in the patient in front of you. For this, the N of 1 or single patient randomized crossover trial can be great. And you know, the clinicians sort of do that already. We give a patient a pill and we simply ask, did it work? But what if we did that formally with pre-specification, blinding, placebo, repeat trials? Then we would know how therapy Z works in patient Z. And pediatric researchers from the University of Texas, Houston did this in teenage kids with high blood pressure. Their study question was, which blood pressure meds work best to treat high blood pressure in selected patients? And this is an ideal question for N of 1 trial because children with high blood pressure are increasingly prescribed medications, but A, there's no evidence pointing to the best therapy, and B, there's lots of practice variation in the prescribed drugs. So the researchers enrolled patients, about 32, who were documented to be hypertensive, and they used ambulatory blood pressure monitoring. And then they underwent cycles of trials with amlodipine, HCTZ, and lisinopril. The endpoint was, as they defined it, preferred therapy. And this was, their definition was best blood pressure lowering with the lowest side effects. And they found that lisinopril met the criteria for preferred med in about half the patients. And within patient variation in blood pressure was considerable. For instance, the best performing medicine reduced blood pressure by 12 millimeters of mercury more than the worst performing medicine. Also, get this, the medicine selected by the N of 1 trial was different from the pre-trial or doctor-selected medication in over half the patients. I'm pretty sure that Daryl Francis and his colleagues at the Imperial College in London are doing an N of 1 trial for statin side effects, and I think this will be great. And I'm certainly no expert in methods or trials or stats, but gosh, it seems to me N of 1 trials hold great promise for personalizing therapies. So if someone who knows a lot about this topic and is listening, please feel free to leave a comment on the heart.org website or respond on Twitter. And also, I found a fantastic summary from the James Lynn Library, and I'll link that summary in the show notes. Second topic is about heart failure readmissions, and yes, it feels like Groundhog Day, because there is yet another ecological study on the Hospital Readmissions Reduction Program, HRRP. This particular study looked at heart failure readmissions around the time of the announcement and implementation of the penalty. But unlike prior studies, this study also considered heart failure diagnoses when they were secondary diagnoses. For instance, the principal diagnosis is MI or pneumonia with heart failure, or some other diagnosis with heart failure. Not surprising is that once the penalty was announced, readmissions decreased, not just when heart failure was the primary diagnosis, but when this study showed that also when it was a secondary diagnosis. A little surprising from this finding was that after the period of the higher penalties, readmissions plateaued and did not decrease further. Doctors Greg Fonarow and Bobak Zayan have written an incredibly clear editorial that accompanied this study, and they trace the history of this program and lay out the intended and unintended consequences. And here are 6 take-home messages from their beautiful editorial. First, Goodhart's Law. Goodhart's Law says that once a measure of performance is financially incentivized, it becomes useless as a measure. Second, now the goal of the policymakers was a good one. They knew that many heart failure readmissions increase cost, and many of these are avoidable. And methods to reduce readmissions were certainly available, but they were underused. So the CMS decided to incentivize lower readmissions with penalties. They used a stick rather than a carrot. And indeed, the HRRP did result in fewer readmissions. And the intended goal of reducing readmissions was to induce hospitals and doctors to improve inpatient care. For instance, give more of the appropriate medicines and improve transitions to home. However, the unintended result of the HRRP was probably not to do those things, but instead to induce gaming of coding. In other words, make people look sicker on paper, which, by the way, I hate. Also, gaming the admission process by triaging more readmissions into, say, the home or observational settings. And sadly, the HRRP program hurt safety net hospitals more, and as such, it acted as a regressive tax on the most vulnerable patients within strained healthcare systems. So another unintended consequence was fewer dollars going to vulnerable health systems. And finally, and I think most concerning to the authors and to me for sure, are that numerous studies now show an association between the HRRP and an increase in mortality. That's right, increased mortality. Thus, the two doctors, editorialists write, it's possible this policy may have harmed thousands of patients. The take-home here, I think, for me, is policy changes are like therapies. They're like pills and procedures. They should be studied before being rolled out. And finally, if you use a measure of quality to pay humans, it ceases to become a good measure of quality. Third topic today is about insulin pricing and healthcare policy. This week, Eli Lilly announced the launch of a lower-priced version of insulin in the United States, and this news got me interested in learning more about how a 100-year-old medicine, one that millions of people literally depend on, became so expensive. And now we all know there are many news reports, and I'm sure some of you have seen patients who have gotten into trouble because they are spreading out their insulin or missing doses entirely. Insulin pricing has gone up around tenfold over the past decade. And the message is here, the story exposes the downsides of our profit-driven U.S. healthcare system. Now, originally, I learned that Frederick Banting sold the patent for insulin to the University of Toronto for $1, because he wanted the product to be widely available. And Lilly made insulin first, originally from other animals, but then synthetic mimics of insulin became available. But generic makers had little interest in entering the market. So in 1999, Eli Lilly sold about $700 million worth of insulin in the United States, but get this, in 2017, Lilly took in $2.6 billion on insulin sales. And the spike in pricing began about 10 years ago. Now, one reason was that doctors were reluctant to prescribe older insulins, and thus there was no reason to make them. Then, of course, the insulin companies played the usual game of using new patents on slightly different versions of the drug. Patent disputes further reduced the incentives for generic makers to get in. But that's not the only impediment to cheaper alternatives. FDA regulations played a role too. Here it gets into the weeds about insulin being regulated as a biologic starting in 2020. And Chuck Grassley's Senate Finance Committee is having hearings, and you can bet that the recent price reduction from Eli Lilly stemmed from this pressure. And I would say that no healthcare system is perfect, and while the U.S. and its medical industry has contributed greatly to scientific progress, the downside here is obvious, and that medical industry is in business to maximize value for their shareholders. Now, when I was younger, I would have thought government needs to come in and regulate these companies and just stop this nonsense. But my older self wonders whether or not the facade of a free market rather than an actual free market is what inhibits generic competition. So maybe the answer is less government intervention so that generics would have a better chance. Now, make no mistake, I claim no expertise in health economics, and I know this gets a little bit into politics, but I think about this topic because it affects my patients with diabetes. Next topic is how to best evaluate patients with chest pain. Now, this is an important question because millions of patients present with chest pain. Anatomic imaging with coronary CT angiography, or CTA, allows a clinician to actually see the disease. And the other way is with functional stress testing, which indirectly assesses for ischemia and also gives important information on the functional capacity of the patient. So in 2015, an RCT called the PROMISE study studied these two strategies in 10,000 patients, and it measured completely legitimate primary endpoint of four things: death, MI, unstable angina, and procedural complications. And the authors of PROMISE found no difference in outcomes, essentially no difference. And Andrew Foy from Penn State and I and others published a meta-analysis of all the trials comparing the two strategies in patients with chest pain. And we found that when you included only trials that compared CTA versus functional stress testing, there was no difference in outcomes, but CTA did lead to more catheterizations and more revascularization procedures. So then this week, the authors of the PROMISE study published a sub-study, a post-hoc study, in the journal American College of Cardiology, JACC, which purported to show that in patients with diabetes who present with chest pain, a CTA strategy resulted in fewer adverse CV events than a functional stress testing strategy, and therefore, quote, CTA may be considered as the initial diagnostic strategy in this subgroup. I wrote a column on this paper because I was shocked that such a flawed analysis made it into such a prominent journal. And here's a brief summary of the flaws. First, the authors changed the endpoint of interest. In the main PROMISE trial, it was a four-component composite endpoint: death, MI, unstable angina, and procedural complications. But for the post-hoc study, after the data was known, they chose CV death and MI. Second point, statistically, despite 10,000 patients in the main PROMISE study, it was underpowered because event rates were lower than predicted. So this subgroup included only 1/5 the size of the main trial, so obviously it's hopelessly underpowered to detect any real differences. And this underpowering, of course, led to a spurious result. And I say spurious because the actual event rates, which were buried in Table 11 in the supplement, showed that the number of MIs in the CTA arm was 3.5-fold lower in patients with diabetes than in those without diabetes. Think about that. Slow down. How is it possible that people with diabetes had a 3.5-fold fewer MIs than those without diabetes? Of course, it is not. So I hope you read this paper, take a look at my column. We also have a news story on this. And I think that this sort of thing makes it into an influential journal, and that CTA is being promoted without evidence is problematic for two reasons. One, we know that anatomic imaging leads to more procedures but not better outcomes. And that's low-value, flat-of-the-curve care. More importantly, I think, publication of this paper exposes flaws in our peer review and adjudication of science. Final topic today is about paclitaxel devices in peripheral artery disease. So I looked up the definition of the word saga, and I found a long, involved story or account or series of incidents. And by that definition, the events of the last few months surrounding increased rates of death in paclitaxel-coated stents is surely a saga. Our journalist Patrice Wendling has a beautiful recap of the recent events and covers a 1.5-day summit convened to discuss this saga. One, as Patrice writes, is rocking the vascular community. So it all began this winter when Greek authors published in the Journal of the American Heart Association a meta-analysis of RCTs comparing DES, paclitaxel, versus non-coded interventions, and their data was stunning. At 2 years, with 12 RCTs, more than 2,300 cases, they report a massive 3.4% increase in death with drug-coated devices. And at 5 years, the risk of death increased with the devices went to 6.6%, which is a number needed to harm of only 14. And the authors bolstered their data with a meta-regression which showed a significant relationship between exposure to paclitaxel and the risk of death. And they did a trial sequential analysis which excluded a false positive association with 99% certainty. And that was just the beginning. Patrice chronicles the subsequent events, which include multiple ongoing RCTs that were halted, also multiple observational studies that have been published that do not find this association, and then Medtronic announcement that they inadvertently omitted mortality data from a table in one of the RCTs, and finally that researchers for the Zilver PTX randomized trial, they issued a correction of 5-year outcomes that now shows a significantly higher all-cause mortality with the paclitaxel device. So what's weird about these findings to me is, how is it possible that paclitaxel increases death? I mean, the drug is used in much higher doses in oncology, and I don't know of any such signals. And I mean, a drug-eluting stent in a leg, that is a tiny dose of drug. Nonetheless, evidence trumps plausibility. And the good news is it sounds like researchers that met at the forum plan to do a patient-level meta-analysis of the trials to help sort this out. And this definitely needs to be sorted out. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider subscribing, giving us a review so that others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.